Welcome back to the deep dive. Today, we're embarking on a really crucial journey into a condition that profoundly shapes a child's early development and, well, if missed, their adult life too. Developmental dysplasia of the hip, or DDH.
Hmm.
Now, this isn't just about a hip that's, out of place. It's actually a fascinating spectrum, from really subtle instability right through to complete dislocation.
Yes.
And the long-term implications of missing it are truly significant. We're talking about potential disability, early onset osteoarthritis, sometimes needing a hip replacement even before someone hits 60.
Quite startling, isn't it?
It really is. That's why understanding this condition, diagnosing it early, and intervening effectively is just paramount. To guide us through this complex landscape, I'm joined by Professor Mo Imam. Professor, from your perspective, what makes DDH such a persistent and vital area for clinicians to really master in today's practice?
Well, thank you. It's a pleasure to be here.
Yeah.
And you've really hit the nail on the head there. DDH it's far from a static condition.
Right.
It's dynamic. It's an evolving developmental process, which is precisely why we've moved away from that older term, congenital dislocation of the hip.
Because it implies it's there from birth.
Exactly. It's simply not always detectable right at birth. And its presentation can indeed change, sometimes quite dramatically, as a child grows. And the statistics really drive home its importance. It's estimated to affect somewhere between 1% and 3% of all newborns.
1 to 3%? Wow.
Yes, and quite strikingly, it contributes to nearly a third, about 29% of primary hip replacements in individuals under the age of 60.
29%, that's huge.
It is. So for any clinician involved in child health, from the community pediatrician right through to the orthopedic specialist, a nuanced understanding of its presentation, the diagnostic hurdles, and the array of management strategies is not just important, it's fundamental.
That's a powerful way to frame it. You've already hinted at it, but let's unpack DDH a bit more precisely. When we talk about it being a spectrum, what exactly does that encompass? How do you differentiate between the various levels of severity?
Absolutely. So when we speak of DDH as the spectrum, we're essentially talking about a range of severity in abnormal hip development. At its mildest, we have what's called acetabular dysplasia. This is where the hip socket itself, the acetabulum, is shallow or underdeveloped. It just doesn't provide enough coverage for the femoral head, the ball part of the joint.
Okay, so the socket's too shallow.
Precisely. Then there's subluxation. Here, the femoral head is partially displaced from the acetabulum. There's still some contact between the articular surfaces, but it's not that proper concentric fit. The ball isn't sitting quite right in the socket.
Partially out.
Yes. And finally, at the most severe end, we encounter complete dislocation. In this case, there's no contact whatsoever between the femoral head and the acetabulum. The ball is completely out of the socket. And this variability, this range, and the fact that it's a process that unfolds over time rather than being a single birth defect, well, that's why developmental has rightly replaced congenital in the name. It's a really crucial distinction for clinical understanding and ultimately for management.
That distinction does reframe how we should think about it, definitely. And when we look at the numbers, how prevalent is DDH? Are there particular demographic patterns or populations where we tend to see it more frequently?
Yes, the incidence rates do vary somewhat. A lot depends on the screening methods being used.
Okay.
If we look at clinically diagnosed cases, say, in populations that aren't routinely screened, the prevalence is often cited around 1.3 per 1,000 live births.
Right.
However, when populations undergo clinical screening using those specific maneuvers like the Ortolani and Barlow tests, that figure rises quite significantly. It can be anywhere between 1.6 and perhaps 28.5 per 1,000.
That's a huge range.
It is. And if you then look at places with universal ultrasound screening, the detection rate can be even higher. What this wide range really underscores is that many of the milder instabilities, especially those picked up only by ultrasound, will actually often resolve spontaneously. They get better on their own without any intervention at all.
Okay, so some self-correct.
A good proportion, yes. As for demographic patterns, they are quite distinct. Females are disproportionately affected.
Right, you hear that often.
Yes, they account for roughly 80% of cases. That gives us a ratio of about 6 females to every 1 male affected.
6 to 1. Why is that?
It's largely attributed to the influence of maternal relaxin hormone. This hormone causes increased ligamentous laxity, the sort of stretchiness in the ligaments, which can be more pronounced in female infants.
Ah, okay.
We also see a higher incidence in certain ethnic groups, Native Americans and Laplanders, for example. Conversely, it's notably rare in individuals of African descent.
Interesting.
Anatomically, the left hip is involved more frequently. About 60 to 64% of cases involve the left hip.
The left side. Any reason for that?
It's often linked to the common fetal position in utero, the left occiput anterior position. In this position, the baby's left hip can be pressed against the mother's lumbosacral spine, which might limit abduction or outward movement of that hip, potentially putting more constraint on that joint.
Fascinating. And bilateral.
Yes, about 20% of cases present as bilateral, affecting both hips simultaneously.
It really is fascinating how all these factors, genetics, hormones, even fetal positioning, seem to converge. Beyond these demographic trends, what are the absolute key risk factors that should immediately raise a clinician's suspicion? The things that make you think, right, I need to investigate this further.
Excellent question. And these are the factors we really need to have ingrained in our minds. Beyond those demographic predispositions we just discussed, the single most significant risk factor is breech presentation.
Right, breech babies.
Absolutely. For infants born via a vaginal breech delivery, the risk of DDH is substantially increased, potentially up to 17 times higher.
17 times.
Yes. And even with an elective cesarean section for a known breech presentation, the risk remains about 7 times higher than a standard head-first or cephalic presentation. This risk seems particularly pronounced with frank breech or single breech positions, maybe less so with a footling breech.
Okay.
And interestingly, procedures designed to reduce the time spent in breech, like an external cephalic version trying to turn the baby, or a pre-labor C-section, might actually mitigate some of this risk.
That makes sense. What else?
Another crucial factor is being the firstborn child. This accounts for around 60% of cases.
60%. Why firstborns?
The thinking is it relates to an unstretched uterus and perhaps tighter abdominal muscles in first-time mothers. This could lead to increased compression and potentially restricted fetal movement compared to subsequent pregnancies.
I see.
Then there's a positive family history. If there's this dysplasia in the family, that significantly elevates the risk. We see about a 5% increased risk for siblings and an estimated 6% recurrence rate overall.
So genetics plays a role.
It certainly seems to. Genetic studies are starting to pinpoint specific genes like COL2A1 and DKK1 that appear to be implicated in some familial cases.
Right.
And then there's a really critical and importantly modifiable factor: swaddling practices.
Ah, yes, swaddling. You hear conflicting things.
Well, the evidence here is fairly clear for DDH. Cultures where infants are traditionally swaddled very tightly, with their legs kept fully straight, extended, and held together, adducted. They show a markedly higher incidence of DDH.
Straight legs held tight.
Yes. Conversely, cultures where babies are carried in a position of wide abduction, think of a straddle or jockey position on the mother's hip or back, tend to have a lower incidence.
So hips spread, flexed.
Exactly. It really highlights the mechanical influence of how we position babies after birth on their hip development. It's a powerful message for parent education.
Definitely. Any other major risk factors?
Yes, any form of in utero restriction also increases the risk. Things like oligohydramnios, too little amniotic fluid, or macrosomia, which is a larger baby, or multiple pregnancies like twins or triplets. Anything that limits the fetus's ability to move freely in the womb.
Okay. Limited space.
Exactly. And finally, infants with certain neuromuscular disorders, conditions like cerebral palsy, meningomyelocele, or arthrogryposis, have a higher propensity for DDH. This is often due to atypical muscle tone or associated skeletal development issues.
Right.
It's also worth noting that post-term gestation is considered a risk factor, whereas interestingly, prematurity is not associated with an increased risk.
Okay. Post-term, yes. Preterm, no.
Correct. And one final point for clinicians. Late-presenting DDH, the cases diagnosed after 3 months, often have fewer of these classic antenatal risk factors. But a history of that tight, straight-legged swaddling is frequently more common in these specific later cases, so it's always worth asking about swaddling practices.
That's an incredibly important practical point about swaddling and late presentation. So, with these risk factors in mind, how does DDH actually manifest pathologically? What's going on physically with the hip's development, and how does knowing that help us with our clinical assessment?
Well, the pathophysiology, the underlying mechanism of DDH, is essentially a disruption of that beautiful, dynamic relationship between the femoral head, the ball, and the acetabulum, the socket, during development.
That interplay you mentioned.
Exactly. That interference can happen either in utero or during early infancy. Think of it like this. A healthy acetabulum starts off quite shallow in the fetus, maybe 65 degrees at 6 weeks. It needs to progressively deepen to a full 180 degrees to properly cup and contain the femoral head.
But it needs to grow deeper.
Precisely. At the same time, the femoral head itself is growing quite rapidly. Now, if this delicate dynamic interplay is disturbed, perhaps due to those risk factors we just discussed, like breech position or improper swaddling restricting movement, then the femoral head ends up being inadequately covered by the acetabulum.
The socket doesn't develop properly around the ball.
That's a good way to put it. And in cases of chronic dislocation, this leads to a whole cascade of anatomical distortions. The articular cartilage at the rim of the acetabulum thickens, forming a ridge called the limbus. In older infants, this limbus could actually invert, fold inwards, and become a significant mechanical block to getting the hip back in place.
So it physically blocks reduction.
Yes. The pulvinar, which is a sort of fibrofatty tissue cushion within the acetabulum, becomes hypertrophied. It gets thicker and takes up space. The ligamentum teres, a small ligament inside the joint, elongates and thickens, as does the transverse acetabular ligament at the bottom of the socket.
So multiple structures change.
Absolutely. All these structures can effectively become barriers, preventing the femoral head from sitting nicely and concentrically within the socket where it belongs. Furthermore, the hip capsule itself, the lining around the joint, can become constricted, particularly where the iliopsoas tendon crosses it, creating what we sometimes call an hourglass configuration that further physically impedes reduction.
An hourglass shape.
Yes, tightening in the middle. And over time, these abnormal mechanical stresses lead to further adaptive but ultimately pathological changes in the bones themselves.
What kind of changes?
You'll often see increased femoral anteversion, the twist in the thigh bone, and increased acetabular anteversion, the orientation of the socket. The femoral head might flatten. The acetabular roof becomes more oblique, steeper, and less concave, less cup-shaped, and the medial wall of the acetabulum can thicken. It's a truly progressive deformation of the joint if left unaddressed.
Whoa.
And interestingly, clinically, we often observe associated packaging deformities. These are essentially other conditions that can result from that same intradermal constraint.
Like what?
The two most common ones are congenital muscular torticollis, a twisted neck seen in about 20% of DDH cases, and metatarsus adductus, an inward turning of the foot in roughly 10%. So seeing those should also raise your index of suspicion for DDH.
Right, look for associated conditions.
Exactly. Understanding these underlying pathological changes really gives us a framework for interpreting what we're feeling and seeing during our clinical examinations. It explains why the hip feels unstable or why movement is restricted.
That's a brilliant explanation of the progressive nature of these changes. So with that pathological understanding as our foundation, let's move to the clinical examination itself. The signs clearly evolve with age, as you've said. Can you walk us through the critical physical examination findings, stage by stage, from the newborn period right up to the walking child? What should clinicians be looking for specifically at each age?
Indeed, the clinical presentation shifts quite distinctly with age. Serial examinations are absolutely crucial because what you're looking for in a tiny newborn is quite different from what you'd expect to find in a toddler. For infants under 3 months old, the primary goal of our physical exam is to detect palpable hip instability, either subluxation or dislocation. The two cornerstone tests here are the Ortolani and Barlow maneuvers.
Right, the classic tests.
They are. The Ortolani test aims to reduce a hip that is already dislocated. With the baby lying supine, hips flexed to 90 degrees, knees bent, you gently apply anterior pressure to the greater trochanter, the bony prominence on the outside of the hip, while smoothly abducting the hip, moving it outwards.
Okay.
A distinct, palpable clunk of entry. You literally feel the hip pop back into the socket, signifies a dislocated hip that is, importantly, reducible.
The clunk of entry.
Exactly.
Yeah.
Conversely, the Barlow test screens for a hip that is currently in the socket but is dislocatable. Starting from the same position, you apply gentle posterior pressure, pushing backwards on the inner thigh near the hip, while adducting the hip, bringing it towards the midline.
Okay, opposite pressure.
Yes. A click of exit, or a palpable sense of the femoral head slipping out of the acetabulum, indicates the hip can be dislocated.
Click of exit. Got it.
Now, it's absolutely vital to remember what these tests do and don't detect. They primarily pick up instability hips that are either dislocated but reducible, Ortolani, or located but dislocatable, Barlow. They won't necessarily pick up an irreducible, dislocated hip one that's stuck out, or a hip that's dysplastic, shallow socket, but currently stable.
Important limitations.
Very important. Also, these tests become increasingly difficult to perform accurately and, frankly, less reliable after about 2 to 3 months of age. This is because soft tissue contractures start to develop around the hip, making it less mobile.
Okay, so a limited time window for these tests.
Yes, and a crucial distinction needs to be made. Differentiate between that significant clunk of an Ortolani reduction, or the palpable displacement of a Barlow, versus benign hip clicks.
Benign clicks.
Yes, these are very common in newborns. They're often to soft tissues like tendons snapping over bony prominences. They feel quite different, higher pitched, less substantial than a clunk, and aren't usually significant for DDH on their own.
Right, clicks versus clunks.
Precisely. While you might observe asymmetry in the gluteal or thigh skin folds, remember this can be present in up to, say, 27% of perfectly normal babies. So asymmetrical skin folds alone are not a reliable standalone indicator of DDH.
Not on their own, okay.
The Galeazzi sign, comparing knee heights with hips and knees flexed, might show a limb length discrepancy, but again, not definitive alone in this very young age group. By far the most important and often the earliest reliable sign, particularly after the first few weeks, say after 8 weeks, is limited and asymmetrical hip abduction.
Limited outward movement.
Exactly. When the hip is flexed to 90 degrees, you gently try to abduct both hips outwards. If you're finding significantly less than 60 degrees of abduction on one side, or a noticeable difference between the two sides, that should be a major red flag for potential DDH.
Less than 60 degrees abduction, that's key.
It really is, especially as the Ortolani and Barlow become less useful. Now, as children move into the 3 to 6 months age bracket, the physical signs change somewhat, often because the hip, if dislocated, becomes more fixed in that position.
Right, contractures develop.
Exactly. Unilateral limitation and asymmetry of hip abduction remains probably the most reliable sign in this age group. Often the hip is now in a fixed, dislocated position. The Galeazzi, or Alice sign, becomes more prominent and reliable here. To perform this, you lay the child supine, flex their hips and knees to 90 degrees, making sure their pelvis is level, and place their feet flat on the examination table. Then you compare the height of their knees from the side.
Looking for different knee heights.
Yes. And a current shortening of the thigh bone, the femur, on one side meaning one knee is lower than the other, strongly suggests a posterior hip dislocation on that side.
Okay.
However, you do need to be wary of false negatives. If the child has bilateral dysplasia, both knees might look level even if both hips are unstable. Or if the pelvis isn't perfectly flat on the table, that can skew the result.
Right, potential pitfalls.
Yes. Other, perhaps later or more subtle signs to look for in this age group might include a widened perineum, a flattening of the buttock on the affected side, persistent asymmetrical thigh skin folds, or sometimes a subtle external rotation posture of the affected leg, particularly when the child attempts to bear weight.
Okay.
Then for older children, specifically the walking child, usually over 1 year old, the presentation shifts again, often related to gait.
How they walk.
Exactly. You'll still observe limited hip abduction, even when the hip is fully flexed. A painless limp is a very common presentation in this age group. It's often the reason they're brought in.
Painless limp. Interesting.
Yes, the child adapts. Some children might resort to toe walking on the affected side. This is often a compensatory mechanism for the limb length discrepancy caused by the dislocation.
Right, trying to even things out.
Precisely. Pelvic obliquity, where one side of the pelvis appears higher when standing, is also frequently seen. In cases of bilateral dislocations, which we said is about 20% of cases, you might notice an increased lumbar lordosis, an exaggerated inward curve of the lower back. This is often compensation for hip flexion contractures.
The sway back appearance.
Yes, and the classic Trendelenburg gait is a hallmark sign in these older children. This is due to weakness or inefficiency of the hip abductor muscles on the affected side. When the child stands on the affected leg, the opposite side of the pelvis drops.
The hip drop sign.
Exactly. The Klasik test can also be useful here. You place your index finger on the anterior superior iliac spine, ASIS, and your middle finger on the greater trochanter. An imaginary line connecting these 2 points should normally point towards or slightly above the umbilicus. If it points inferior to the umbilicus, it strongly suggests an underlying hip dislocation.
A useful bedside test.
It can be. Finally, just to reiterate about bilateral dislocation. Because both hips are affected, diagnosis can be particularly challenging, especially after the neonatal period.
Because the asymmetry is missing.
Exactly. The classic asymmetrical signs we rely on, the Galeazzi sign, asymmetrical skin folds, asymmetrical abduction limitations, they may well be absent. Instead, these children typically present with a characteristic waddling gait and that hyperlordosis we mentioned. A high level of clinical suspicion is absolutely paramount in these specific scenarios to avoid missing the diagnosis.
That's a truly comprehensive breakdown by age. It really highlights just how dynamic the clinical picture is and why repeat examination is so important. So once we've done our clinical examination and have a suspicion, imaging clearly becomes pivotal. When should a clinician opt for an ultrasound versus an X-ray? And what precisely are we looking for in these studies to confirm our suspicions or classify the severity?
Imaging is indeed critical, but the choice of modality is absolutely age-dependent. And this hinges primarily on the ossification process of the femoral head when the bony center of the ball starts to appear.
Okay, bone development is key.
It is. Let's start with screening recommendations. All infants require ongoing physical exam screening at their routine checks until they are confidently walking. Now, the idea of universal ultrasound screening for all babies remains quite controversial in many places, including here in the UK.
Why the controversy?
The main argument against it is that many minor instabilities or shallow sockets detected by early ultrasound will actually resolve spontaneously without any treatment. Therefore, screening everyone hasn't been definitively proven to be cost-effective or to significantly improve overall outcomes compared to selective screening plus clinical examination. Public Health England, for instance, doesn't currently recommend universal ultrasound screening for all infants.
Okay, so not for everyone routinely.
Not routinely everywhere, no. However, selective ultrasound is widely recommended for babies identified as being at high risk. Ideally, this ultrasound should be performed within 6 weeks of age, even if their physical exam seems entirely normal.
Which babies fall into that high-risk category?
This includes infants with a first-degree family history of hip problems in early life, unless DDH was definitively ruled out in that relative. It includes babies who had a breech presentation at or after 36 weeks gestation, or were breech at delivery if born earlier than 36 weeks. And importantly, in the case of multiple births, if any baby meets these criteria, then all babies in that pregnancy should ideally be scanned.
Right, scan all multiples if one is high risk.
Yes. The American Academy of Pediatrics also advises a hip ultrasound at 6 weeks for these high-risk patients despite a normal examination. Ultrasound is also a key tool for monitoring progress during Pavlik harness treatment or clarifying those equivocal clinical exams where you're just not sure.
And what if the exam is inconclusive in a newborn?
For newborns with an inconclusive clinical exam or perhaps just those benign hip clicks, it's often sensible just to repeat the clinical examination in 2 to 4 weeks. Give it a little time. But crucially, if you find a positive Ortolani or Barlow maneuver, a definite clunk or dislocation, then immediate referral to an experienced pediatric orthopedic specialist is absolutely non-negotiable.
Okay, positive test means immediate referral.
Without delay. Now, beyond about 4 months of age, the physical exam becomes less reliable as the capsule tightens up. And critically, the femoral head starts to ossify, to become bony, typically between 4 and 6 months. At this point, X-ray becomes the preferred imaging modality.
So ultrasound before 4-6 months, X-ray after.
It is the general rule, yes.
Yeah.
And a useful point. Normal pelvic radiographs obtained at 4 months of age can reliably exclude significant DDH in children who are considered at risk.
Good to know. So what are we looking for on these images? Let's start with ultrasound.
Okay, dynamic ultrasound is our primary modality for infants from birth up to about 4 to 4.5 months. It's important to remember that you can get spurious results, false positives, if it's performed too early, say before 4 to 6 weeks of age. This is due to physiological immaturity. The joint is naturally quite lax then.
Right, wait a few weeks.
Ideally, yes. Ultrasound allows us to evaluate both hip stability dynamically. We can actually watch the hip move under stress and the acetabular development statically. It gives us a clear view of the bony acetabular anatomy, the cartilage femoral head, the labrum, the cartilage rim, the ligamentum teres, and the hip capsule. When we're looking at acetabular dysplasia on the static ultrasound images, we often use the graph classification. This relies on measuring 2 key angles. The alpha angle is formed between the bony roof of the acetabulum and the sidewall of the ilium. A normal value is typically greater than 60 degrees, indicating good bony coverage.
Alpha angle over 60.
Correct. The beta angle is formed between the cartilaginous labrum and the ilium. A normal value here is typically less than 55 degrees, indicating a well-positioned labrum.
Beta angle under 55.
Yes. On a normal ultrasound, the femoral head should also appear well-centered, usually bisected by a line drawn down from the ilium. The graph classification then categorizes hips from class I, normal, right through to class 4, dislocated, based on these angle measurements and the position of the femoral head. This classification directly helps guide our treatment decisions.
Okay, graph classification guides treatment based on angles.
Exactly. Now, once that femoral head ossification center has developed, typically after 4 to 6 months, pelvic X-rays become the primary imaging modality. The standard view is an enteroposterior AP view of the whole pelvis, ensuring it's well positioned.
AP pelvis X-ray.
Yes. For identifying hip dislocation, we use several key lines and measurements drawn on the X-ray. Hilgenreiner's line is a horizontal line drawn through the triradiate cartilages, the growth plates at the bottom of the sockets. The bony femoral head ossification center should normally lie inferior to this line.
Below Hilgenreiner's.
Correct. Perkins' line is drawn perpendicular to Hilgenreiner's line, down through the very lateral bony edge of the acetabular roof. The femoral head ossification center should normally lie medial to this line, in the inner lower quadrant.
Medial to Perkins.
Yes. And Shenton's line is a continuous smooth arc that should follow the inferior border of the femoral neck and continue along the superior margin of the obturator foramen, that hole in the pelvis. Any break or disruption in this smooth arc indicates an abnormality, usually superior displacement of the femur.
Shenton's line should be unbroken.
Exactly. Delayed ossification of the femoral head itself is also a common finding in dislocated hips. And later, the development of a normal-looking acetabular teardrop structure on X-ray after reduction is generally considered a good prognostic sign.
Okay, what about measuring the dysplasia itself on X-ray?
For assessing hip dysplasia, the shallowness of the socket, the key measurement is the acetabular index, AI. This is the angle formed between Hilgenreiner's line and a line drawn tangential to the lateral ossific margin of the acetabular roof. Essentially, it measures the slope of the socket roof.
Measuring the roof slope?
Yes. It should normally be less than 35 degrees at birth, and it should decrease as the child grows, ideally becoming less than 25 degrees by 6 months to 1 year of age. A higher angle means a shallower, more dysplastic socket.
AI decreases with age, ideally 25 by 1 year.
Correct. Another measurement, used more reliably in older children, typically over 5 years old, is the center edge angle, CEA of Wemberer. This is the angle formed by Perkins' line, a vertical line through the center of the femoral head and a line drawn from the center of the femoral head out to the lateral edge of the acetabulum. A value of less than 20 degrees is considered as normal, indicating insufficient lateral coverage.
CEA of Wemmerberg. For older children, 20 is abnormal.
Yes. Now, sometimes we need more detailed imaging, particularly around surgery. An arthrogram involves injecting contrast dye into the hip joint under anesthesia, usually during a closed or open reduction procedure.
Dye in the joint.
Yes. It's incredibly valuable for confirming that a concentric reduction has actually been achieved. We look at how the dye pools, ideally less than 5 millimeter, medially indicates good reduction. A medial dye pool greater than 7 millimeter is a poor prognostic sign, often associated with increased risk of AVN.
Okay, checking the dye pool.
Exactly. And critically, the arthrogram helps the surgeon identify any anatomical blocks to reduction that might need addressing. We're looking for things like that inverted labrum or limbus, a contracted transverse ligament, the hourglass capsule constriction, a thickened pulvinar, or a hypertrophied ligamentum teres. It shows what's physically stopping the hip going back in properly.
Visualizing the blocks?
Precisely. Finally, CT and MRI scans also have their place. CT was historically the standard for evaluating hip reduction after closed reduction and spica casting to check the position inside the cast.
Right, CT post-casting.
Yes. But MRI is increasingly favored for this now, primarily to minimize radiation exposure to the child. MRI has the added advantage of being able to identify potential perfusion abnormalities in the femoral head, which might predict or help prevent a vascular necrosis.
MRI avoids radiation, shows blood flow.
Correct. These advanced imaging techniques, CT and MRI, are generally reserved for more complex cases, for surgical planning, or for detailed post-operative evaluation when we need a really clear picture of the soft tissues, cartilage, or bony anatomy.
That's an exceptionally clear guide through what can seem like a confusing array of imaging options and lines. Now, this brings us to the core of clinical management. For our audience of mid-senior professionals, what are the current evidence-based management pathways for DDH? How are they tailored by age and severity? And perhaps what's one common pitfall or misconception you see clinicians sometimes make when navigating these pathways?
Right. This is indeed where the rubber meets the road, isn't it? The overarching goal of all DDH treatment is undeniably to achieve an early, concentric, and stable reduction of the hip joint.
Early, concentric, stable.
Those are the key words. This is absolutely paramount if we want to allow for normal hip development and prevent long-term degeneration and osteoarthritis.
Right.
However, it's a critical point to make, and perhaps a common misconception is underestimating this, that the risks, the complexity, and the potential complications of treatment unfortunately escalate significantly with delays in diagnosis.
The later you find it, the harder it is to treat.
Essentially, yes. And while early detection and treatment are absolutely crucial, they don't entirely eliminate the need for subsequent surgery in every single case. Studies indicate that even with successful initial treatment, for example with splinting, almost 6% of those infants may still require some form of surgery later on.
Okay, so early treatment doesn't guarantee no future surgery.
Doesn't guarantee it, no, but it gives the very best chance. Now, onto the specific management pathways by age. For newborns, in the first 4 weeks, 0 to 4 weeks, if you identify mild instability, perhaps a slightly clicky hip, but without a truly dislocatable hip on Barlow testing observation, can be a perfectly appropriate initial approach.
Watch and wait for mild instability.
Yes, because a remarkable number, perhaps up to 90%, of these very mild early instabilities will actually spontaneously resolve within 6 to 8 weeks as the initial hormonal laxity wears off.
Okay, but what if it's definitely dislocatable?
If the hips are genuinely dislocatable, meaning a positive Barlow test, or already dislocated but reducible with an Ortolani test, then early referral to an experienced pediatric orthopedic surgeon is essential.
Right. Refer dislocatable hips.
Interestingly, some studies suggest that for these early, clearly unstable but reducible hips, waiting up to about 30 days before initiating active treatment, like a harness, shows no significant difference in outcome compared to starting treatment immediately. This allows for some potential physiological resolution first.
A brief window for potential self-correction even if unstable.
Potentially, yes, in that very early neonatal period. Now, for infants age 1 to 6 months, the first-line treatment for confirmed DDH is typically abduction, splinting, or bracing. And the gold standard here is the Pavlik harness.
The Pavlik harness, yes.
This harness is indicated for reducible hip instability or dislocation in infants under 6 months of age. It's crucial to note its contraindications, though. It should not be used for teratologic hip dislocations, those associated with syndromes or neuromuscular conditions, or in patients with conditions like spina bifida or significant spasticity, because it relies on the baby's own normal muscle function and movement within the harness for success.
Needs normal muscle function.
Exactly. The technique involves anterior straps that flex the hips up to about 90-100 degrees, preventing extension, while posterior straps gently prevent adduction, keeping the legs apart. It positions the femoral head towards the acetabulum.
Flexion and abduction.
Correct. It's generally worn for 23 hours a day initially for at least 6 weeks, or until the hip is demonstrably stable, both clinically and on ultrasound or radiograph. We monitor progress regularly, perhaps every few weeks initially. Weaning from the harness happens gradually, usually over another 6 to 8 weeks, once hip stability is consistently achieved, and we see evidence of normal anatomical development on imaging.
Okay, gradual weaning. How successful is it?
The success rate for the Pavlik harness is generally high, around 90% for Barlow-positive hips, dislocatable but in. It's slightly less successful for Ortolani-positive hips, already dislocated.
Higher failure if already out.
Yes, a bit lower success rate there. And here's a potential pitfall. There's a significantly higher failure rate if Pavlik treatment is initiated late, say after 7 weeks of age. It's also less likely to succeed in multigravidas in males or if the child has significant associated foot deformities.
So earlier initiation is better.
Much better. And the most critical decision point for clinicians using the Pavlik harness, and perhaps the most common serious error is missing this, is to discontinue the harness if the hip is not clinically and radiographically reduced within 3 to 4 weeks.
Stop if not working by 3-4 weeks. Why?
Because continuing to hold a hip in marked flexion and abduction when it's not reducing properly can lead to a severe complication called Pavlik disease. This involves erosion of the posterior and superior rim of the acetabulum, essentially damaging the socket by pressing the unreduced femoral head against it. It prevents proper socket development.
Right, can actually harm the socket.
Precisely. So if reduction isn't achieved promptly, the harness must come off. In such cases, a switch to a semi-rigid abduction brace might be considered as a second-line non-operative option, or more likely, moving towards reduction under anesthesia.
Okay, what if DDH is diagnosed later, say between 6 and 18 months? Or if the Pavlik harness fails?
In those scenarios, diagnosis between 6 and 18 months of age, or following Pavlik harness failure, closed reduction and spica casting becomes the preferred approach.
Closed reduction under anesthetic.
Yes. This procedure is performed under general anesthesia. The surgeon gently reduces the hip using an Ortolani maneuver, flexing, abducting, and lifting the greater trochanter gently to guide the femoral head back into the socket. A key point here is to avoid excessive force during the reduction attempt. Being too forceful significantly increases the risk of damaging the blood supply and causing avascular necrosis, or AVN.
Gentle reduction is crucial.
Absolutely. An arthrogram, injecting that contrast dye, is typically used intraoperatively to confirm that a concentric reduction has truly been achieved. We're looking for that minimal medial dye pool, ideally less than 5 millimeters, and ensuring there's no interposition of the limbus or other structures blocking reduction. As mentioned, a medial dye pool greater than 7 millimeters is a poor prognostic sign, strongly associated with an increased risk of AVN later.
Arthrogram confirms reduction and checks for blocks.
Exactly. An adductor tenotomy, releasing the tight adductor tendon in the groin, may also be performed at the same time if there's significant tightness limiting abduction or if an unstable safe zone is observed, meaning excessive abduction is needed to maintain the reduction.
Release the groin tendon if needed?
Yes. Post-reduction, the hip is immobilized in a spica cast. This is a large cast extending from the chest down to the ankle on the affected side and usually incorporating the other leg to the knee for stability. It holds the hip in the desired position, typically around 100 degrees of flexion, 45 degrees of abduction, and neutral rotation for about 3 months, often called the human position. The aim is to keep abduction generally less than 55 degrees to minimize pressure on the blood supply and reduce AVN risk.
Spica cast in the human position.
Correct. Reduction within the cast is then confirmed, usually with a CT scan, often using selective cuts to minimize radiation, or increasingly with an MRI scan. The cast is typically changed at around the 6-week mark, perhaps for cleaning or to adjust the position slightly. The overall failure rate for closed reduction and spica casting is estimated to be around 13–14%.
Okay. What about children diagnosed even later, over 18 months?
For children older than 18 months, or in cases where a closed reduction attempt has failed, open reduction and spica casting is usually indicated.
So surgery is needed now?
Yes, open surgery. The primary purpose of an open reduction is to directly visualize and surgically address any anatomical blocks that are preventing a concentric reduction. These are the things we saw potentially on arthrogram, the inverted labrum or limbus, the thickened pulvinar, the hypertrophied ligamentum teres, the tight iliopsoas tendon causing capsular constriction. The surgeon physically removes or releases these obstacles. An adductor tenotomy is also commonly performed if needed.
Deal with the blocks directly.
Exactly. There are different surgical approaches. The most common is the anterior approach, often called the Smith-Peterson approach. This is generally preferred for patients over 12 months old. It gives good access, allows for capsulorrhaphy, tightening the capsule after reduction, and is thought to have a slightly lower risk of AVN compared to the medial approach.
Anterior approach most common over 1 year.
Yes. A medial approach through the groin is less invasive and can sometimes be used, particularly in infants under 12 months. It's associated with potentially less blood loss, but it doesn't allow for easy capsulorrhaphy and historically carried a slightly higher AVN risk, although techniques have improved. Examples include the Ludloff, Weinstein, and Ferguson approaches.
Medial approach as an option, especially younger infants.
Correct. Post-operatively, after open reduction, the hip is again immobilized, often in a slightly different functional position, maybe 30 degrees of flexion, 30 degrees of abduction, and 30 degrees of internal rotation. This is held in a spica cast, and reduction is confirmed with imaging like CT or MRI.
Okay. Now, what about children who still have residual hip dysplasia even after these reductions, perhaps when they're a bit older, say over 2?
Right, this is where we often move into the realm of osteotomies procedures, where we surgically cut and reshape the bones to improve the hip's mechanics.
Cutting the bone itself.
Yes. If the issue involves the femur, a femoral varus derotational osteotomy, or VDRO, might be indicated. This can be done to shorten the femur slightly, which can facilitate reduction in difficult cases and decrease the tension on the joint, thereby potentially reducing AVN risk. It also corrects excessive femoral anteversion, inward twist, or coxa valga, increased neck shaft angle. VDRO is generally best performed in younger children, typically under 4 years old, when remodeling potential is still good.
VDRO for femoral issues, usually under 4 years.
Correct. More commonly, especially for residual acetabular dysplasia, we perform pelvic osteotomies. These aim to reshape or reorient the acetabulum itself to provide better coverage for the femoral head. They're indicated when there's insufficient coverage, often evidenced by an increased acetabular index on X-ray, reflecting severe dysplasia. These are more commonly employed in older children, generally over 4 years, because the natural potential for the acetabulum to remodel and deepen decreases significantly as the child ages.
Pelvic osteotomies for the socket, usually over 4 years.
Yes. And there are various types, often sounding like alphabet soup, but each serves a very specific purpose in redirecting the socket.
Okay, let's try and break down the main ones.
Right. We can broadly group them into reconstructive and salvage procedures. Among the reconstructive ones, aimed at creating a more anatomical joint. The Salter osteotomy involves a single transverse cut through the ilium bone just above the acetabulum. The distal fragment, containing the socket, is then hinged forward and outward at the pubic symphysis. It primarily improves anterolateral coverage at the front and side. It's suitable for younger patients where the triradiate cartilage, that crucial growth plate in the socket, is still open. A potential side effect is it might lengthen the leg slightly, maybe by about a centimeter.
Salter. Single cut, open triradiate, improves anterolateral coverage.
Exactly. The triple osteotomy, like the Steele procedure, builds on the Salter by adding cuts to the superior and inferior pubic rami. This provides more mobility to the acetabular fragment, allowing for greater correction, and is often used in slightly older children, but still typically with an open triradiate cartilage.
Triple. Salter plus pubic cuts, more correction, open triradiate.
Yes. Now, a real game changer, particularly for adolescents and young adults, is the periacetabular osteotomy, or PAO, often associated with GANS. This is a more complex procedure involving multiple osteotomies cuts in the pubis, ilium, and ischium, very close to the acetabulum itself. Critically, this procedure requires the triradiate cartilage to be closed.
PAO. Multiple cuts, closed triradiate.
Correct. While technically demanding, the PAO allows for a very precise three-dimensional correction of the acetabular orientation. A key advantage is that it maintains the integrity of the posterior column of the pelvis, which usually allows for earlier weight-bearing after surgery compared to some other large osteotomies. It truly revolutionized hip preservation surgery.
PAO allows 3D correction, early weight bearing.
Yes. Then there's the Pemberton osteotomy. This is an incomplete osteotomy that starts near the anterior inferior iliac spine, AIS, and curves posteriorly towards the ilioscale limb of the triradiate cartilage. It's used for moderate to severe DDH, and crucially, the triradiate cartilage must be open. It improves anterolateral coverage and also reduces the overall volume of the acetabulum. It's generally quite stable and often doesn't require internal fixation like screws or plates.
Pemberton. Curved cut, open triradiate, reduces volume, stable.
Good summary. And the Degas osteotomy is somewhat similar, but involves incomplete cuts extending from the acetabular roof down towards, but not necessarily through, all limbs of the triradiate cartilage. It's often favored in neuromuscular dislocations, like in cerebral palsy or where there's significant posterior acetabular deficiency. It can be tailored to improve anterior, central, or posterior coverage, and like the Pemberton, it reduces acetabular volume and is usually stable without internal fixation.
Degas. Incomplete cuts, open triradiate, good for posterior deficiency CCP, stable.
Precisely. Now, for older patients, say over 8 years old, where the femoral head might be significantly subluxated or deformed, and achieving a truly concentric anatomical reduction is no longer possible, or perhaps even desirable, we might consider salvage pelvic osteotomies.
Salvage procedures when reconstruction isn't feasible.
Exactly. The aim here is more about improving stability and load distribution to delay symptoms, rather than perfect anatomy. The shelf osteotomy involves adding an extra articular buttress of bone graft laterally, essentially building a new roof extension over the uncovered femoral head. Its success relies on fibrocartilage forming over the graft to create a functional joint surface.
Shelf. Adds a bony buttress laterally.
Yes, and the Chiari osteotomy involved cutting the ilium above the acetabulum and displacing the entire lower fragment, including the socket, medially, inwards. This provides better coverage by shifting the socket underneath the upper ilium, and again relies on fibrocartilage metaplasia for its long-term success.
Chiari medializes the socket.
Correct. Finally, for adolescent and adult hip preservation surgery in patients with symptomatic dysplasia, but before significant arthritis sets in, the periacetabular osteotomy, PAO, particularly the Bernese PAO technique, is the key procedure. As we discussed, it's for hip pain related to a shallow acetabulum with femoral head under coverage, provided the triradiate cartilage is closed and there are no advanced signs of joint degeneration. It aims to reorient the patient's own healthy cartilage into a better mechanical position to hopefully prevent or significantly delay the need for a hip replacement.
PAO, again, key for adolescent adult preservation.
Absolutely. So as you can see, the surgical approach is incredibly nuanced, highly dependent on the patient's age, the specific anatomical problem, the state of the cartilage, and the surgeon's expertise. There's no single best operation. It's about choosing the right procedure for the right patient at the right time.
That deep dive into the osteotomies really clarifies their distinct roles and the sheer complexity of surgical decision-making. Thank you. Now, even with such meticulously tailored interventions, complications can, of course, arise. What are the primary concerns clinicians should be mindful of during and after DDH treatment, and how do these influence the long-term outlook for patients?
You're absolutely right. Despite our best efforts and sophisticated techniques, complications remain a significant consideration in DDH management. The most severe complication, and the one that we constantly strive to prevent across all treatment modalities, from harnessing right through to complex osteotomies, is a vascular necrosis, AVN, of the femoral head.
AVN, yes, damage to the blood supply.
Exactly. Its incidence can range quite widely, perhaps from 0 up to 15% or even higher in some series, depending on the treatment and the age group. It occurs when the delicate blood supply to the femoral head is disrupted, leading to the death of bone tissue in the ball of the hip joint.
What increases the risk of AVN?
Several factors are known to significantly increase the risk. These include applying excessive or forceful abduction during reduction or casting, particularly forcing the hip beyond about 60 degrees of abduction. A history of previous failed closed treatment also increases risk, as does repeat surgery. And as we mentioned with arthrograms, that finding of a large medial dye pool greater than 7 millimeters during a closed reduction attempt is a strong predictor of subsequent AVN.
Okay, excessive abduction is a key one to avoid.
It is. The mechanism often involves impingement or stretching of the posterior-superior retinacular branches of the medial femoral circumflex artery, which are the main supply to the epiphysis. Prevention is paramount. We must always ensure abduction is kept within the safe zone, that range between maximal passive hip abduction and the angle of abduction where the femoral head starts to displace when the hips are flexed to 90 degrees. Finding and staying within that zone is critical during reduction and casting.
The safe zone. How is AVN diagnosed?
Radiographically, the diagnosis often becomes apparent over time. Signs include the failure of the ossific nucleus, the bony center, to appear or grow normally about 1 year after the reduction. You might see broadening of the femoral neck, increased density or fragmentation of the ossified femoral head itself, and ultimately residual deformity of the proximal femur, like flattening of the head, cossa plana, or a short, broad neck, cossa magna. It's a devastating complication that can fundamentally alter the long-term prognosis, often leading to premature arthritis despite an initially successful reduction.
A very serious complication. What else should we look out for?
Beyond AVN, other concerns include redislocation or persistent subluxation. This has an approximate 10% recurrence rate, even with what seems like appropriate initial treatment. Joint stiffness can also be an issue after prolonged immobilization or surgery. Surgical interventions, of course, carry the general risks of blood loss and infection. Specific to Pavlik harnessing, there's a risk of transient femoral nerve palsy, usually due to excessive hip flexion pressing on the nerve. This is seen in about 2.5% of cases, but typically resolves if the harness flexion is reduced or the harness is removed promptly.
Femoral nerve palsy with the harness.
Yes, and we already discussed Pavlik disease, that erosion of the posterior-superior acetabulum from prolonged harnessing of an unreduced hip. It emphatically underscores the importance of that 3 to 4 week rule for discontinuing the harness if reduction isn't achieved. Other minor harnessing complications can include skin irritation under the straps and rarely pelvic erosion or even knee subluxation if not fitted correctly.
Okay. And what about the long-term consequences if DDH goes entirely untreated?
Well, if DDH goes untreated, the long-term consequences are truly severe and life-altering for many. Patients can experience significant functional disability, chronic hip pain, and noticeable gait abnormalities such as that Trendelenburg gait or compensatory toe walking.
Major functional impact.
Absolutely. And perhaps most alarmingly from a public health perspective, untreated or inadequately treated DDH is a major preventable contributor to premature degenerative joint disease and early onset osteoarthritis. As I mentioned right at the start, it's estimated to account for up to 9% of all primary hip replacements performed, and a really striking 29%, nearly a third of primary hip replacements in individuals younger than 60 years old.
Those statistics are really sobering. It hammers home the profound impact of this condition across a person's lifespan if it isn't addressed effectively in childhood.
It truly does. It highlights why early detection and appropriate management are not just about correcting a childhood problem, but about preventing significant adult morbidity.
Absolutely. This leads to the crucial question then. What does the long-term prognosis actually look like for treated DDH? And are there particular scenarios where the outcomes tend to differ significantly?
The prognosis for treated DDH is, quite rightly, heavily dependent on several crucial factors. These really are the initial degree of dysplasia or instability, the child's age at the time of diagnosis and when treatment was started, and critically, whether a truly concentric, stable reduction of the hip joint was successfully achieved and then maintained throughout growth.
Degree, age, and quality of reduction.
Those are the key determinants, yes. For many neonatal hips with just mild instability or very mild dysplasia, perhaps those that are only Barlow positive or have graph ultrasound angles like an alpha between 50-60 degrees, showing maybe 50-60% bony coverage, a remarkable 90% or more will spontaneously resolve with observation alone, leading to excellent long-term functional and radiographic outcomes.
Most mild cases resolve well.
Yes. When a Pavlik harness is applied appropriately, particularly before 6 months of age, for those hips that do require treatment, it boasts that very impressive reduction success rate of around 95%.
High success for Pavlik if used early.
Very high. However, and this is important for long-term follow-up, it's important to acknowledge that some degree of residual dysplasia can still persist, even after what we consider appropriate and successful initial treatment. For instance, approximately 20% of cases initially treated successfully with a Pavlik harness may still show some subtle shallowness or undercoverage of the acetabulum later on.
Residual dysplasia in 20% even after Pavlik?
Roughly, yes. This really necessitates consistent clinical and radiographic follow-up, usually until skeletal maturity, to monitor the hip's ongoing development and ensure that remodeling continues effectively. We need to make sure the socket catches up, essentially. Generally speaking, having a completely normal hip X-ray by the age of 2 years is considered a strong indicator of a good long-term prognosis for future hip health.
Normal X-ray at age 2 is a good sign.
It's a very encouraging milestone, yes. Now, outcomes certainly differ significantly in scenarios involving delayed diagnosis, particularly in older children where the hip has been chronically dislocated for an extended period before treatment is initiated.
Right, the late cases.
Yes. For instance, in cases of bilateral dislocations diagnosed in patients who are already, say, 6 years of age or older, perhaps surprisingly to some, these patients often actually function better in the long run if their hips are not surgically reduced.
Better off not operating on older bilateral cases?
Often, yes. Attempting complex reductions and reconstructions in these older children with long-standing bilateral dislocations can sometimes lead to more harm than benefit. The hips may have formed pseudoacetabula, false sockets, the risk of complications like AVN and stiffness is much higher, and the functional outcome might actually be worse than leaving them adapted to their dislocated state. It's a very difficult decision.
A challenging balance. What about unilateral?
Similarly, for unilateral dislocations diagnosed late, say if the patient is over 8 years old, evidence suggests that better long-term functional outcomes may sometimes be seen without surgical intervention to reduce the hip. An epiphysiodesis, a procedure to slow growth on the longer normal side, might still be considered to help manage any resulting limb length discrepancy, but attempting a major hip reconstruction carries significant risks.
Again, observing might be better over 8 years for unilateral.
Might be. These scenarios really emphasize that the hip's natural remodeling potential decreases significantly with age. Attempting a reduction in an older, chronically dislocated hip, especially if the acetabulum is severely dysplastic and perhaps deformed, can sometimes lead to more complications if the socket simply cannot adapt or adequately contain the femoral head. It becomes a complex decision-making process, weighing the potential benefits against the substantial risks in the older child with neglected DDH.
That's a crucial nuance, isn't it? Understanding when perhaps not intervening surgically might lead to a better functional outcome in these very late-presenting cases. Considering all these outcomes, what preventive strategies can we actively champion, particularly thinking about patient and parental education? What's the most effective message we can convey?
Prevention of DDH, or at least mitigating its impact, fundamentally revolves around 2 pillars: early identification through screening and promoting proper infant care practices, particularly regarding hip positioning.
Screening and safe practices.
Exactly. Universal hip screening at birth, meaning a thorough clinical physical examination performed by experienced clinicians for every newborn, remains absolutely crucial. Even if universal ultrasound screening isn't standard practice everywhere, this meticulous physical exam is the cornerstone of early detection.
The clinical exam is key for all babies.
It is. However, a key primary prevention strategy, one which is perhaps often overlooked but is incredibly impactful and relatively simple, is parental education on safe swaddling techniques.
Back to swaddling again.
Yes, because it's so important and modifiable. As we discussed, traditional swaddling practices that rigidly keep a baby's legs fully extended and adducted straight and held together can significantly increase the risk of DDH by creating unfavorable mechanical forces on the developing hip joint.
The straight leg swaddle is the problem.
That's the main concern, yes. We must actively advise parents, caregivers, and even other healthcare professionals about hip-healthy swaddling. This means positioning the infant's hips in slight flexion and abduction, knees bent, hips allowed to fall open naturally within the swaddle. Crucially, the swaddle should allow for free movement of the hips and legs.
Hips bent and free to move.
Precisely. The avoidance of forced or sustained hip extension and adduction, especially during those critical first few months of life, is essential for allowing proper hip socket development. This education should ideally be initiated and reinforced by midwives, health visitors, pediatricians, and GPs to all new parents, perhaps even before hospital discharge. It's probably the single most effective modifiable primary prevention message we can convey regarding DDH.
Hip healthy swaddling education for all new parents.
Absolutely. Beyond swaddling, advocating for early and regular pediatric or GP checkups is vital. These routine well-child visits provide multiple opportunities for healthcare providers to consistently monitor the child's hip development over time, performing those age-appropriate examinations we talked about.
Regular checks are important follow-up.
Yes, and any suspicious findings, or if an infant is identified as having significant risk factors even with a normal initial exam, should prompt a timely referral to pediatric orthopedic specialists for further evaluation, usually including imaging. This collaborative and proactive approach combining careful, repeated physical examination, targeted imaging where appropriate, and that crucial parental education on hip-healthy practices is truly our best defense against the serious, long-term complications of DDH.
So bringing this all together then, what does this really mean for us as healthcare professionals? Collaborating across different disciplines, trying to optimize outcomes for these young patients. What's the core message you'd like our listeners, many of whom are on the front lines of child health, to take away from our deep dive today?
I think the core message is that the effective management of developmental dysplasia of the hip is fundamentally a team effort. It truly demands a highly interprofessional approach, starting right from the beginning.
A team effort.
Absolutely. Early identification is the first and arguably the most critical step. This responsibility largely falls upon our primary care colleagues, the pediatricians, the family physicians or GPs, physician associates, specialist nurses, health visitors, midwives. Their vigilance during routine newborn checks and subsequent infant physical examinations is absolutely paramount. Catching those subtle signs early makes all the difference.
Vigilance in primary care is key.
It is. Then comes the proper utilization of diagnostic technology, knowing when to opt for ultrasound versus X-ray, based on the infant's age in the clinical presentation. Using the right tool at the right time is crucial for confirming the diagnosis accurately without unnecessary radiation exposure or diagnostic delay.
Appropriate imaging.
Yes, and equally important is ensuring a timely referral to a specialist service when instability or dysplasia is detected or even just strongly suspected based on risk factors or examination findings. Guidelines from organizations like the American Academy of Pediatrics, the AAOS, the British Orthopedic Association, and various national screening committees provide clear, evidence-based frameworks to help guide this process of identification and management.
Follow the guidelines for referral.
Indeed. The evidence is quite clear that while minor hip instability often resolves spontaneously, for those hips that don't, early intervention is highly effective. We know the Pavlik harness, for example, achieves that excellent 95% reduction rate if it's applied appropriately before 6 months of age. But we also have to remember that even with appropriate treatment, some degree of residual dysplasia can occur. This underscores the need for continued surveillance, often coordinated by primary care practitioners in collaboration with specialists, potentially right up until skeletal maturity in some cases. This ongoing monitoring is vital to catch any late-presenting issues or consequences of earlier treatment.
Continued surveillance is important.
Very much so. Ultimately, our collective goal as healthcare professionals involved in the care of infants and children must be to diagnose significant DDH well before 6 months of age whenever possible. Achieving this early diagnosis and initiating appropriate management significantly reduces the risk of those devastating long-term complications. We've discussed things like a persistent limp, leg length discrepancies, chronic pain, and most notably, the development of early-onset osteoarthritis that can severely impact a patient's quality of life, sometimes starting even before their 4th decade.
Aim for diagnosis before 6 months.
That should be the aim. It truly underscores the profound and lasting impact that our collaborative efforts in detecting and managing this condition can have on a child's entire life trajectory.
What an incredibly insightful deep dive into developmental dysplasia of the hip. We've truly covered so much ground, from its early nuanced presentation and the diagnostic challenges, right through to the multifaceted treatment landscape and the absolutely critical importance of early intervention and that collaborative interprofessional approach you just highlighted.
Hmm.
It's clear that while the complexities of DDH are significant, a thorough understanding, vigilance, and working together can genuinely change a child's long-term future for the better. If you found this deep dive valuable today, please do take a moment to rate and share it with a colleague who might also benefit from these insights. And finally, perhaps a thought for you to consider as you go about your practice. As diagnostic tools continue to evolve, particularly things like AI analysis of imaging or perhaps even genetic markers, what might the future hold for even earlier, maybe less invasive, or more accurate detection of DDH? Could this potentially reshape our current screening paradigms completely? Professor Moimam, thank you so much for sharing your invaluable expertise and guiding us through this complex topic today.
It's been my pleasure. Thank you for having me.
And to you, our listener, thank you for joining us on the deep dive. We'll see you next time.